like to thank the organizers for the invitation to this symposium again. So keeping on the theme of translational research, I'm going to talk about drug delivery systems for allergic eye disease. These are my disclosures. So all of you will know that basically allergic eye disease is a continuum that affects a lot of our patients, almost up 5 to 30% of our population itself. And you'll all be aware of the symptoms that our patients have with itchiness, redness, and foreign body sensation and tearing and photophobia. And if it's very bad, certainly in children, it can certainly affect their quality of life. There's a whole spectrum of allergic eye disease, and VKC, or vernal keratoconjunctivitis, conjunctivitis, is probably one of the most severe forms, and there's different phenotypes of VKC, depending on whether it's either mixed, limbal, or basically palpable as well. In Asia, we may see more of the mixed type as opposed to the limbal phenotype, which is a bit more common in European countries as well. And one of the things that's really changed in the management of VKC over the years has been a paradigm shift in basically where we introduce immunomodulated therapy in the treatment. This paper from here that was done by the Movia study group in Asia basically shows you how there's been a shift into basically starting immunomodulated therapy, such as basically with cyclosporine, earlier in the treatment before actually even starting topical steroids. The paradigm shift really came about from these two publications, basically the VECTOR study, and it was the introduction of low-dose cyclosporine by Santen to this cationic formulation using 0.1% cyclosporine dosing that really has basically shown that we should really think about starting cyclosporine therapy early in our patients, and actually even if you basically have to give steroid therapy for any breakouts with respect to an increase in inflammation, you can actually cut down the duration that they actually need to use topical steroids, and of course all the side effects that go along with topical steroids as well. So clearly there's basically a bit of an unmet need itself in any basically topical formulation itself, because there are actually very few formulations that are basically available. One of the other things is that actually we know that actually tacrolimus is a far superior drug to basically cyclosporine because it has almost 50 times amount of efficacy itself because of its mechanism of action itself. But again, there are very few commercial available preparations. Eye drops themselves, of course, they're in a suspension formulation, so they can cause blurring of vision. There's always an issue basically with compliance itself, and especially if you use basically tacrolimus, this can cause a lot of irritation itself. And often if you do have to use tacrolimus, most of us basically will use Protoptic as a skin cream and use it onto the eyelid, which is an off-label use. It's very difficult to get commercialized formulations. Senju Pharmaceuticals in Japan do it, but otherwise it's actually quite difficult to get it. The other option basically is to try to compound it, and there can be a large variability in the dosing itself. So there's several hurdles with basically the use of basically standard of care, which is obviously cyclosporine. It can be a slow onset of effect, poor bioavailability, barriers to basically patient compliance, and of course this can have a significant effect basically in the child's quality of life, and also with the parents, because of course the fact that the parents have to administer the eye drops for the children as well. So one of the ways of getting around this is to think about using a nanotechnology-based system to basically put it as a drug delivery. And if you're looking at nanotechnologies, there's several different formulations like you can see from this schematic over here, from nanoemulsions all the way down to nanoparticles and lipid nanoparticles as well. And we're going to be talking about nanoliposomes, which is the technology that we developed in basically Singapore itself. One thing to understand is that basically you have a choice of basically doing cyclosporine or tacrolimus, and the reason why basically we've chosen to go with basically tacrolimus is the fact that we know tacrolimus, even though it has a similar mechanism of action, is way more potent than cyclosporine itself. And the limitations have been the lipophilic structure of tacrolimus, and that's why we don't have an eye drop basically available, and that's why most of the companies have gone with basically cyclosporine itself. But we thought if we're going to make a drug delivery system from scratch, let's go with basically the stronger drug, where we know there's basically a lot of efficacy from there. So we started basically in this concept a few years ago. So this is one of our publications back in 2018. And the concept was basically put this onto a sustainable release microfilm, where you can see in this animal model that we used, that we're able to get pretty good sustainable release above basically therapeutic concentrations. This is basically using in vitro data and comparing it to basically in vivo studies. And this is using the allergic eye disease model and basically show an effective outcome with respect to release profile. But it only lasted basically about a month when we basically put it into a film itself. And we thought in a practical circumstances, this is not going to really be very clinically translatable as well. So we switched then basically to using a nanoliposomal formulation itself. And this is basically the basis of the formulation we use. So it's basically made of cholesterol, so POPC, basically synthetic lipid base. It's because the tacrolimus is very lipophilic, so it basically goes into the coating over here itself. And on initial in vitro studies and also in vivo release studies in rabbits, we were able to basically get about a 3-month basically release profile. So we thought, okay, this is quite reasonable. We could basically have a 3-month release from one subconjunctival injection of the Lipotac as well. And we also thought administration was a little bit easier as well. So this is the manufacturing process of basically how you can actually manufacture this liposomal basically formulation. Initially, obviously, most of the studies were done in-house in the engineering university in Singapore and NTU. And now you'll see later on when we go to commercial clinical trial, we get it formulated in this company called Formulatica, which is based out of Australia as well. So the in vitro studies on the left-hand side basically targeted that this is the release profile that you get. So you get initial burst and you get a concentration or release profile up to 100%, up to about maybe 6 to 8 weeks. This is doing in vitro basically testing. And when this is tested above therapeutic concentration, which is equivalent to what you get with an eye drop, what you can see below with this line over here itself, you can see you can maintain well above basically eye drop basically topical concentration of tacrolimus, well up to basically about 7 or 8 weeks itself above basically the target dose. And we stop the experiments basically over here itself. If you inject this into a rabbit eye and then basically you retrieve, you can see the difference in the concentration on the ocular surface in the rabbit when you basically take the rabbit conjunctiva and then basically look at the concentration of basically tacrolimus. These ones in the brown bars over here itself is the liposomal injection. The one in the green is basically the topical therapy. So you can see the variation you get in basically topical therapy dosing compared to the sustained release that you get with the liposomal concentration. We then basically went back to the same efficacy model that we basically used before. So this is basically using a rodent model. This is a mouse model that's used a lot for basically animal studies. And you can see from the bar chart over here itself, compared to blank control, we're able to show a good efficacy with respect to reducing the inflammatory response in this basically animal disease model of inflammation. If you take basically the corneas out and you basically look at inflammatory cytokine markers, either using immunohistochemistry on the left-hand side or qPCR, we looked at basically IgE-mediated inflammatory responses through typical interleukins 4, 5, 13, and CD40L. These were all basically reduced by over the 4-week time period following basically the Lipotac formulation itself. So with the animal data, we did basically the efficacy data. We then thought, okay, now it's time to basically think about basically taking this to a human clinical trial. This is the actual formulation that we basically use for the patients. So this is actually what's actually in the actual vial that you basically get. So you can see the dosing of basically tacrolimus, water basically for injection itself. This can be stored in a normal refrigerator and then just basically taken up into a syringe. We then basically prepared a dossier, as you'll have to do for any translational research. We had to do GMP batch studies, which were basically coming from Australia. The GLP toxicology studies were actually done in India. We then had to do pharmacological studies for PK/PD release profiles, then made a dossier, submitted this to basically HSA for clinical trials application, and obviously got basically an IRB. So the whole of this process took the best part of almost 1.5 to 2 years to basically get done. This is the release criteria for the tacrolimus before it's basically sent to the physician. You have to basically look at the quality of the product itself, the pH, the stability, and also obviously has to be sterile with respect to endotoxin basically use as well. So this is what basically comes in the vial. And this is our basically developmental timeline. Now we're basically up to basically just completed the phase 1 study in Singapore. This is how you get it in the clinic. So it comes in a little vial like this. I'm just transferring it to the girls to get out of the fridge. I'm just transferring it to basically a 1 ml syringe over here. So it's done basically in a clean room. So you don't need to do this in OR. You can do this basically either in a treatment room or basically you can do this on a slit lamp over here on this side. This is one of the boys who has VKC. So these, in the first-in-man trials, we took children that basically were controlled with VKC, not on any steroid therapy, but basically were just using cyclosporine. Then we stopped the cyclosporine and we gave them basically tacrolimus, and they have a whole battery of tests, including tear film cytokine analysis and also blood tests to look at the tacrolimus level inside the blood as well to see what the absorption effect is as well. So we've just completed the first-in-man study at the end of last month, and now some of these children are basically following up over the 3 to 4 month period to see if they get any flare-ups of their VKC as well. So the main advantage of this drug delivery system is it's got superior effectiveness and bioavailability. You have sustained release, so you have much better control of the VKC, and a simple subconjunctival injection will last, we think, basically 3 to 4 months without having the patient basically having to come back, and there's obviously going to improve compliance. It's safe. So far, we've had no issues basically with the injection, and there's no issues in systemic absorption or basically tacrolimus. And of course, potentially, now we've basically done this as a disease model for VKC, you could potentially use this for other diseases such as graft versus host disease, Stevens-Johnson syndrome, and also MMP as well. To conclusion, allergic eye disease is a common modality. We all basically see this in clinic, and of course, it's increasing in incidence. The spectrum basically with VKC is on the severe side, but they have very defined phenotypes, and that's why we chose this to do our first-in-man basically studies. Obviously, it's particularly common in children as well. There is a paradigm shift on VKC treatment to using less steroid use and to use early use of immunotherapy, typically with cyclosporine. However, obviously, there's issues in formulation availability, especially with basically tacrolimus. Preparation and compliance is a huge issue, and we think LipoTac will basically solve all of these problems, and our first-in-man study so far have been encouraging, and hopefully we will publish this over the next year. Thank you for your attention.
Thank you very much. Now we have time for one question. Do you have any questions for Professor MEHTA? Oh, just a quick one. Like in your phase 1 trial, how many patients you tested? 6, only 6.
Yeah, units. Phase 1 normally basically is 6. It's single dosing, and it's not repeated dose.
And it's only one eye.
It's only one eye. So the other, so what we did was these kids are all. So the problem is that with these kids, they have to be on cyclosporine, completely stable, never taken steroids for basically over 2 years. So they're only on. And then what I did was I stopped the cyclosporine for both eyes, and then we basically have been monitoring them. So actually that kid was one of the first ones that we did. So he had, I think I had it in January and stuff. So actually his other eye now had a bit of a flare-up because I stopped the cyclosporine. So now I've restarted him with cyclosporine on the opposite eye. But so far the eye that had the tacrolimus, he's been absolutely quiet. In an equivalent formulation of they didn't call it LipoTac, in an equivalent liposomal formulation for Xalatan, for glaucoma, when they did their clinical studies, they found that in patients they had stability or effect for almost 4 to 6 months. So you may actually get longer duration of effect itself, but this is basically what we were looking basically around about 3 months. That's what the animal studies for, and that's exactly what they show with Xalatan, but clinically they were able to get longer itself.
Okay. Thank you very much.